let's jump right into it. Welcome to this intensive clinical explainer where we bypass the basics entirely and dive straight into a high-yield synthesis calibrated for that 270-plus threshold. Today, we're running an integrative mixed block simulation. We're going to test your ability to rapidly synthesize intricate mechanisms, nail down discrete management steps, and, most importantly, avoid those critical diagnostic traps. So let's kick things off with the volume deficit in thermal burns. The core mechanism you need to remember here is capillary leak, which drives massive fluid third spacing. This specific pathophysiology absolutely demands aggressive fluid resuscitation using lactated ringers. You've got to calculate this requirement using the Parkland formula. That's 4 milliliters multiplied by the patient's weight in kilograms multiplied by the percentage of total body surface area burned. And the strictly mandated management step? Exactly 50% of that calculated volume must be infused in the first 8 hours post-injury. But there is often a hidden inhalation threat complicating this exact picture. Enclosed space fires critically demand that you evaluate for toxic gases, primarily carbon monoxide. CO binds to hemoglobin with a 200 times greater affinity than oxygen. And this creates an absolute diagnostic trap. It results in a deceptively normal PaO2 on an arterial blood gas. But make no mistake, the patient is suffering from severe functional hypoxia and might even present with that classic cherry red skin. Now, let's look at our first clinical variance, distinguishing between carbon monoxide and cyanide toxicity, since both frequently happen in house fires. The variance here is stark. CO toxicity presents with a headache and that deceptively normal PaO2, which mandates immediate treatment with 100% oxygen. Cyanide toxicity, on the other hand, actively blocks mitochondrial cytochrome C oxidase. It presents with profound lactic acidosis and requires immediate, life-saving treatment with hydroxycobalamin or sodium thiosulfate. All right, transitioning over to oncology, let's examine ductal obstruction. Here, we are looking at an expanding adenocarcinoma in the pancreatic head that is physically compressing the common bile duct. This mechanical blockage is what drives an acute, completely painless, conjugated hyperbilirubinemia. So what is the absolute physical exam marker for this exact obstruction? It's the Courvoisier sign. When you're at the bedside of a jaundiced patient, finding a palpable, markedly enlarged, and completely non-tender gallbladder is a highly specific red flag for malignant extrahepatic biliary obstruction. To back up that diagnosis, serum CA19-9 is often elevated. On top of that, an abdominal CT will reliably reveal a dilated common bile duct alongside dilated intrahepatic ducts. This is known as the double duct sign, and it predictably happens if both the common bile duct and the main pancreatic duct are being compressed by that expanding mass. Let's isolate the clinical variance here between pancreatic head versus body and tail carcinomas. Pancreatic head tumors present early with painless jaundice and steatorrhea exactly because of that common bile duct obstruction we just talked about. Conversely, body and tail tumors completely spare the biliary tree. Because of this, they present late, usually with severe radiating mid-back pain and profound weight loss. Shifting gears now to infectious disease kinetics, let's analyze the erythrocyte rupture caused by Plasmodium falciparum. As the most lethal strain, falciparum drives severe cyclical fevers and cerebral malaria. To manage this, prophylaxis with atofaquone proguanil or mefloquine is required to actively target the blood schizonts. But in stark contrast, Plasmodium vivax and Plasmodium ovale possess a completely unique life cycle stage, the hepatic hypnozoite. Standard blood schizenicides are completely useless against these dormant liver forms, which allows severe relapses to happen months or even years later. And here is where a massive management trap lies. Eradicating these hepatic hypnozoites strictly necessitates the addition of primaquine. However, primaquine triggers catastrophic hemolytic anemia in patients with G6PD deficiency. You must absolutely mandate pre-treatment screening before you even think about administering it. Just to summarize this infectious variance quickly, Plasmodium falciparum requires only standard blood stage therapy. However, Plasmodium vivax and ovale strictly require adding primaquine to eradicate the dormant hepatic forms, assuming, of course, your G6PD screening comes back clear. Okay, let's put it all together into our master case synthesis. Pay very close attention to the clinical clues here. We have a 67-year-old male recovering from recent third-degree burns and smoke inhalation, treated with 100% oxygen. He now presents with painless jaundice and a palpable, non-tender gallbladder. His labs show an elevated CA19-9. Complicating the picture, He recently traveled to India and currently takes chloroquine. So what is the indicated next step? We need to rigorously analyze these 5 distinct management steps to identify the strictly indicated approach. Our options are A. Administer hydroxycobalamin, B. Switch to mefloquine monotherapy, C. Endoscopy-guided biopsy, D. Repeat CT in 3 months, or E. Add primaquine immediately. And the correct answer is C. Endoscopy-guided biopsy. This step directly samples the pancreatic head mass that is causing the common bile duct obstruction and that painless jaundice. By utilizing endoscopy with ultrasonography, you minimize the risk of false negative results and provide the definitive tissue diagnosis required for this highly suspicious malignancy. Let's exhaustively review why the other options are traps. Administering hydroxycobalamin is incorrect. Yes, the patient had smoke inhalation, but cyanide toxicity from a house fire presents acutely with profound lactic acidosis and shock, not as delayed, painless jaundice. Mefloquine monotherapy is also incorrect. His recent travel to India strongly indicates exposure to Plasmodium vivax. Managing vivax strictly requires a drug combination to target both the active blood schizons and the dormant hepatic hypnozoids. A monotherapy like mefloquine is going to fail to prevent relapse. Option D, repeating the CT in 3 months? That is clinically inappropriate. Pancreatic cancer is highly aggressive. The diagnosis must be confirmed immediately to attempt surgical resection before major vascular encasement, like of the superior mesenteric artery, occurs. If that happens, the tumor is fatally rendered unresectable. Finally, option E, adding primaquine immediately, is a lethal trap. While primaquine is needed for VVAX, administering it without first verifying the patient's G6PD status can trigger catastrophic hemolytic anemia. Furthermore, the immediate life-threatening priority here remains investigating the malignant biliary obstruction, not blindly modifying his malaria prophylaxis. So as you head out to the wards, I want you to ask yourself this. When compounding systemic traumas like severe burns and inhalation injuries mask progressive malignancies, are you simply treating the immediate presentation, or are you rigorously interrogating the ultimate pathology? Thank you for joining me for this intensive explainer. Keep pushing your clinical synthesis, and I'll catch you in the next one.